Welcome to another episode of TeqTalk. Every year, nearly 15% of commercial health claims are initially denied, costing US over $19 billion in rework and lost revenue. But behind that friction lies enormous opportunity. Imagine turning the claim process from back office burden into real-time, intelligent engine, one that predicts denials, price accuracy, and pays faster. So today we will explore how TPAs like Lantern and payers are modernizing adjudication with data, automation, and AI that's transforming claim management into value management for employers, providers, and members alike. So joining us today is Falko Buttler, CTO of Lantern, a next generation TPA, redefining transparency and speed, and Paul Risk, the VP of Business Consulting at Teqfocus. Let's dive into how AI is re-engineering trust and efficiency across this claim management. Thank you so much, Falko, and thank you so much, Paul, for joining the podcast today. So before we actually go ahead and deep dive into our topic, for our audience, why don't you introduce yourself?
Sure. Yeah, I'm Falko. I'm the CTO at Lantern Care, joined the company back in March. My background has been in health technology pretty much my whole career, and worked on medical imaging. That brought me to the US 17 years ago. Worked on a mobile app on my own, starting my own business in healthcare. That went viral. It was pretty successful. And then I joined two startups in Silicon Valley from early stage, 10 or 15 employees, all the way through growth and acquisition and going public. Both of them were also in healthcare. One was more health navigation and engaging people around the health. And the second one was in the virtual primary care space. But then kind of the acquiring company Accolade went back into the health navigation space. So I've seen the payer side from both the provider angle as well as now being the TPA or third party administrator. So yeah, great to be here.
Great. Very impressive. Thank you so much, Falko. Paul, we would like to know you more.
My name is Paul Risk. I am the VP of Technology Consulting at Teqfocus. I've been mostly in the insurance space for almost 35 years of my career. That includes in consulting both at Deloitte and Accenture. I was a CIO of an Axis subsidiary where we did federal healthcare TPA claims for Blue Cross Blue Shield plan for federal employees. So quite a bit on that side as well. And CTO of the warranty group, now part of Assurance. So I've been in this space virtually my entire professional life. And I'm one of the few people in my family who didn't become a doctor. So this is how I made up for it, I guess.
So I think we are going to have some interesting stories from different angles today.
Yes.
Great. Thank you so much, Paul. So let's start and deep dive into our topic today, AI and claim management. Very, very interesting. And all of us are somewhere being touched by this process. And I was just talking to Paul before, Falko, you joined, that this healthcare is one of the industries that everyone is attached to, right? This is quite personal. So TPAs like Lantern, they operate as kind of a payer equivalent. They receive the claims and, combine the codes. And once they combine the codes with the rules and all of that, they pay the providers and ultimately bill self-funded employers and unions. So tell me, this is the core high-level model which I have understood of the TPAs, but from your vantage point, really want to understand at the business model level, what makes TPAs like Lantern very, very distinct in today's ecosystem?
I think we're trying to specialize in a particular area of that market. Healthcare is obviously lots of different things, from primary care to mental health to surgeries to there's a large variety of things that are happening within healthcare, and the health insurance typically tries to cover all of that. So they try to be good at a lot of things, but unfortunately they turn out to be not so good in most things. And I think the TPA is trying to bridge that gap and really focus on certain things that they really want to be good at, and then provide value to our customers through that. Mostly, obviously, reducing cost in that process, because that is what unfortunately, healthcare costs keeps going up a lot faster than like inflation in the United States. So we're really trying to counter steer that and helping reduce that growth in cost.
All right. So I think, the cost is one of the very important factors. That's very interesting to know. And zooming out to our broader payer ecosystem, commercial health plans, Paul, I would like to understand from you that how is the business model really evolving if you see from 10 years to now? And now it's like people expect more transparency, faster adjudication, and more predictable medical spend, right? And speed is one of the factors. I believe everybody wants to have everything quickly. It's just like ordering anything in Amazon. It's that level of speed people are looking out for. So tell us a bit about overall broader payer ecosystem, how it's evolving.
Yeah, so everyone wants instant gratification. They're used to Amazon, eBay, Facebook. Things show up the next afternoon or the same afternoon. But in the medical field, it seems to be going in the opposite direction. And where you want transparency, it's still opaque. You ask a simple question, you get complicated answers that don't seem to make much sense even to the person who's giving you the answer. I have a personal story which I'm going to share a little bit later on in the podcast that actually speaks specifically to this. But a claim, I mean, most people can relate to this. We had a claim. I got some bill. I didn't expect what was in the bill. I'm trying to understand, and the person makes answers that sound logical. In some cases, don't make any sense at all. And you're no better off now than you were, weeks ago. It's very personal.
Yeah.
Right. And a lot of us in the industry, we talk about, I'm going to improve this process. I'm going to make my data better. AI is going to solve it. And to the person who's the recipient, the victim of the healthcare system, depending on how you look at it, that doesn't help because as an individual, you see it from this kind of, I got healthcare and I got this bill, as opposed to, I see how the process works. In a way, it's like taking your car to a mechanic. I don't care what you did. Did you fix my car? And is the bill according to your estimate? And in healthcare, sometimes it's, I still hurt and I got this bill I don't understand. So, to answer your question, what are companies doing? Companies are trying to do it with better customer service, AI-enabled chatbots and interfaces, AI built into the system. It wasn't that long ago. Actually, I used to work for the American Medical Association, and it wasn't that long ago that the AMA went from ICD-9 codes to ICD-10 codes. And I was there when they were doing that with the intent of being more refined, improving the process, better codes, better accuracy, more transparency. And yet here we are.
Yeah,
I think maybe adding on to that is also just providing actually access to care. Like you mentioned, it's just so intransparent, and people obviously helping people with claims or bills that they receive, but also often just guiding them through that journey. So a large part of what our care advocates are doing, helping our members just navigating the journey all together, helping them connect to someone who can help them, getting them an appointment, managing everything post surgery or post whatever journey they go through, because this is so just complicated to navigate.
Yeah, I think that's a very valid point. And we have been seeing a lot of changes, right, from last 10 years, if I consider, not even last 10 years, if we talk about last 5 years, we'll see dramatic changes everywhere happening around the healthcare ecosystem as this AI has come up. So we'll talk a bit about AI in later portion. But Falko, I would like to understand from you that Lantern's perspective. So Lantern is basically in between providers billing and employer-sponsored benefits, right? So where do you see most meaningful opportunities to streamline this reimbursement process and enhance the efficiency across the whole ecosystem? Is there any specific area you think could be automated, or you can put some agents or automation which will really help in getting the greatest ROIs?
Yeah, to what Paul mentioned, I think people want to have instant gratification. I think that is also true for getting reimbursed. And I think where we at Lantern really focus on right now is how can we speed up. So we are already incredibly fast. We're processing claims on, I think, 5.8 days on average is what I we heard from our team, which is incredibly fast compared to what you see in the healthcare system typically.
And what is a typical industry-wise? Sorry to interrupt.
Yeah, typical industry, I mean, it's probably 60 to 120 days that you can expect to get.
Oh, wow. That's pretty high.
And there's just a lot of paperwork and lots of just back office work required to do that. I mean, that's one reason why providers really love working with us, because we're a lot faster. But we don't want to be there either. Like, it's still a very manual process. It is very, intensive, going through contracts and the pricing, the adjudication, the reimbursement. So we're really looking at how can we automate that, and we're leaning on AI here as well, to really look at the contracts that we have, the pricing. Pricing should be deterministic, and if you have the same procedure done with the same codes, you should reimburse the same amount, assuming all other variables are the same. And I think what providers get frustrated with if that's not the case, and that causes escalations and upstream escalations as well. So we're really trying to automate that to make that it will not just reduce the amount of time it takes. That is a great side effect of it, but it will also significantly improve the quality and consistency of how we go about that.
Yeah, that's very interesting. And before I actually go to Paul to understand the overall payers ecosystem, Falko, if you can help our audience to understand the whole process starting from the beginning, that how the claim process works in America, and that will be really helpful.
I'm obviously not a claim specialist, so I'm providing this from a technologist angle. But in simple terms, when a provider is done with seeing the patient, they are writing up and submitting a claim. Now that we receive that claim, and then we have a team that is verifying whether that patient actually is someone who is in our network, is actually covered, and does some basic checks, and that is that obviously can be automated. And then we're okay, now we assume this is actually covered by us and the providers in our network, and all of that is true. Then looking at the different diagnosis codes and looking at the contract and actually pricing of how much money we owe this provider based on kind of what they've done. From there, we're collecting that, and then we're submitting a payment. So there's now this financial transaction actually happening, and we're bundling these payments. So we're submitting the payments to the providers. And after that, we need to look at kind of how much we pay to the providers. And now we need to bundle that again and now charge our customer, which is the employer or the union, or in some cases a health plan as well, based on that. And that may be a different calculation, because depending on the pricing models, it could be a per case rate, it could be a PEPM, in which case they're paying somewhat of a flat fee. Could be different ways, or it could be % of savings based on that, charging our customer.
That was very helpful, because that explains the whole claim management, how it starts and what are the steps involved and when it ends actually. But I'm pretty sure there are a lot of complexities inside, denials and a lot of things, which we'll also touch base in between. So you said that when you get the claim until the time of settlement, it takes generally 5 to 8 days. That's pretty fast, I would say. And Paul, coming to you now, when you evaluate this whole industry, right, as overall payer macro, what most limits consistent right first time adjudication? So benefit design complexity, coding variations, data fragmentation, or anything else? What do you think?
The short answer is yes, all those things. So let me give you a personal story, and we'll start from the holistic receiver point of view, and then we'll dig down into the data as I saw it. So about a year ago, I have a son who's in college. I get a phone call at 1 a.m. Think this can't be good. Look at the caller ID. Hospital. This is not good. So we get the phone call no parent ever wants to get. Yeah. And my son's been admitted to the hospital. It's an emergency. I wake up very quickly. I drive the 4 hours to school. He's in the intensive care. Very traumatic for me and my wife. Thankfully, he's okay. He pulls through. I managed to take him home the next day. Then comes dealing with the insurance company. I'm still scarred by it. But this is how many people are introduced to the healthcare system. I've been healthy all my life. My kids have been healthy. And all of a sudden, I get a phone call. Is this the parent of such and such? Come now. So he's okay. So then what happens with the medical insurance? And I'm a professional at this. Falko, you're a professional at this. I think I know what to expect. I do not know what is about to hit me. So according to the policy, and most policies are written similar like this, if you're admitted through the emergency room, your deductible is $400. Some it's $200, it's $100, but for our policy, it was $400, and everything that comes after that is included in that one deductible. So the hospital bill was $31,000 for 20 hours, which they saved his life, so no complaints, no amount too high for your child, and I think it's covered by insurance. It should be covered by insurance. So we get, at least a month and a half, 2 months later, the bills from people I don't recognize, bills from providers who presumably took care of him. There's the big one from the hospital, which actually doesn't show up in the first bill. There's one for the pulmonary care, cardiac care, anesthesiologist, this doctor, that doctor, this nursing group, blah, blah, blah. And they're all coming in, and everyone shows up as denied by insurance.
Oh.
Why? And it turns out they had the wrong insurance. So it's December, and at the end of November, my wife's company had switched insurances. Okay. I call them, and mind you, this is a major university hospital's healthcare system. These are professionals. They know what they're doing. These aren't amateurs. They run it throughout the state. They know what they're doing. Very friendly people, very professional. Yes, sir, we will take care of this. And they do. Except the bills come, and they're still getting denied. So here's how I started putting together. This goes on for 6 months. And then after 6 months, they say, well, yes, we've submitted it, but now it's been too long and they won't accept a claim older than 6 months. And I said, well, whose fault is that? I've been calling you every month. Every time I get the bill, I've been writing, I have a stack of notes this thick of notes and everything you've done. But here's what happened. What I think happened based on my knowledge, and here's other data. At some point, they got his information when he was admitted. And they took whatever health insurance they had from the university, which is when he applied, which is normal. This is why they have it. And then it's not one claim. It's something like 15 claims for the different groups, right? Falk was nodding his head. Different groups are submitting their claims. It's not like I go and my car is being fixed and one provider takes care of it. It's 15 providers. So the health insurance information was pulled from where it was stored and put into 15 claims. So now that incorrect information is in 15 different places. So when I call them and say, fix this claim, they pull up the claim and they fix it, but they don't fix the others. And finally, I figured this out. I say, I think it's in these other claims. Can you fix those? Those haven't been submitted yet. I don't have access to them. Which is a little mind-boggling. So it goes on and on and on and on. I think I don't pay any of them. I keep calling them like, you have to fix this. And they postpone the billing. Eventually I paid them the $400. I think I paid $25 to some physician I probably didn't need to pay, but the last time I talked to them, I think was in August. Knock on wood, I don't hear from them again, but it's been a year. And so what do we have here? We have a situation where the data is not relational. Now, could have an AI fix this? Yes, but what you have here isn't even a data problem, it's a systemic problem. The system did a behavior that sounds good on paper and maybe works most of the time, but it pulled data and then replicated the data, which is sort of a no-no in the data world. You don't want to replicate it. You want to reference that insurance in case it changes. Now I have to fix it in 15 places I don't always have access to. They can see, oh, yes. Yeah. In my head, I'm thinking, I know what happened. You pull the information once and you put it in a different system, which now attaches claim information as you submit it, as you code it. Did they code it correctly? I think so. They eventually paid it and sorted it all out. Eventually, I spoke to a supervisor who he said, I'm going to suspend every claim that we have here with you and send it back to internal review and audit so they can fix this. I presume they did. But to your point, it took, they were telling me 30 or 40 days every time I call them, you'll get it revised. But in a lot of cases, these were taking, 4, 5, 6 months to process. And I didn't understand why. And again, I'm not the one on the hook for it. I paid my piece of it. But the they're taking a long time. If you take too long, the payer is going to say you took too long. Why didn't you submit it sooner? And again, I don't understand why they took so long. This shouldn't be this complicated. So you have systemic problems here where the systems literally feed data to each other. They toss it over the wall with a one-way integration. That's not a good practice in any industry. It's not relationally based. That's a problem. Can I AI fix over that? Probably. But NI, natural intelligence, can fix that too. Probably just takes a little bit longer. And so I think what we have here, you have fragmented systems. A data warehouse can solve most of that, but it doesn't actually solve it. AI can bridge that gap, but it's not an elegant solution. But AI can, make that process go a lot faster. It probably wouldn't have made that mistake saying, hey, you have a different insurance. Let me figure this out and find every claim and retrofit that. So, there's a lot of stuff happening in the background there that makes the process. And the insurance company is having a third party sending letters to see who they can blame for this. And asking me, was another party involved in this? Did these following things happen? Who can we sue? And, you're wondering, well, how much information do you have? Are you supposed to have this information? I don't really want to share this. So, on top of that, there's a subrogation piece of it, which is within their right. But that also adds to a level of stress and question as to what are you doing with my claim?
Yeah.
A lot of moving parts.
Yeah. Thanks, Paul, first of all, for sharing the story. And I really hope no parent should get such kind of time. It's very hard on parents. So can completely understand. And post that, again, 6 months of trauma on paying the bills, confusion, what's happening around. So, but that's reality.
Yeah.
That's how it works. And like how you mentioned, AI can help. But there are so many disconnected systems. I wonder why and please feel free to provide your inputs, that sometimes it feels that there is no centralized top framework because of what it is causing chaos overall. So do you think any framework which will be, for example, be done mandatory for inside all the healthcare system, that you have to follow this framework, probably that can help? Because right now, if it's all so silos, right? It's all so distributed. And where all you'll plug AI, again, it's going to be in different systems, and systems are not connected. It's going to make still complicated unless we connect the system properly and have a proper framework across the healthcare systems.
I mean, you think about how, and this isn't unique to healthcare, you think about how systems grow. 30 years ago, right? You didn't have large-scale systems available you could go out and buy and then tweak. You built them yourselves. So IT departments hired people who could program in what back then was COBOL, AS400, C was coming about. I mean, my first programming language was Lisp for AutoCAD. And all my programming languages I learned in school are extinct. But, some of these, they survive. So they would build these systems to do whatever they needed to be done. And as the healthcare system grew and got more complex, they would modify this, or they would add other systems, right? Now you have this mishmash of systems that may or may not need to talk to each other. That's literally, they all grew up separately. It wasn't an intent to make a silo. This business unit needs this. How
can we really solve this problem? I mean, we are in technology, and for any healthcare expert, right? How can this really be solved? Because this is so complicated.
I mean, you need a holistic point of view. So
no, I mean, there are efforts to get there. I mean, we have like central repositories for medical records, for example, but not everyone participates. So whatever, there's still only a fraction of your records. And often if you go over like state borders, then it stops there. So I think we need like actually a mandated like standard and centralization of these records. Like not just medical records, but also things like claims and your insurance, like actually having like one unique record of like that everyone can pull from of what your insurance is. So like in your case, it would have solved that problem of, now, pulling it in 15 different places rather than just pointing to the one reference they should have looked at in the first place. And obviously your story was very traumatic, but I think all of us experienced something like that, where like you receive claims that were completely untransparent, and you were fighting with different parties that were all trying to collect money from you, and you have no clue whether that is one truthful and how it even got to that. And like one thing I also learned is like, even if you may be a network with that hospital and maybe one of the providers, but maybe not the person who gives you something in that hospital because they happen to be not a network, even though they're literally in the same building, in the same room with that other person who is a network. It is just incredibly frustrating because it is so intransparent. I think we just need more transparency through.
I actually did this once for an insurance company. We came in, they asked 400s, fix it, and I ripped it all out and put it in Salesforce. This was maybe 10, 15 years ago, and that was my solution. And it sounds straightforward today, but it took 4.5 years, $40+ million, and the support of, the business units, my boss, the board, because, you're writing $2-3 million checks every few months. You're betting a lot of money on it, and you sort of put your career at risk. But it can be done. But you go to a hospital system, you're not talking $40 million. You're talking hundreds of millions, if not billions. Airlines have the same problem, mind you, right? They'll share that Sabre system, and when you dig deep underneath the fancy little web interfaces, there's this ancient COBOL system that's sort of driving the whole thing, right? This is why your airline codes are like one letter, because it's literally a single byte character. So this issue faces a lot of older industries that can't just start from scratch and drop in Salesforce and a data cloud and Snowflake and all these modern cloud-based technologies that are safe and secure and easy to configure. They have to rebuild it, and in every case, it's billions of dollars. Other countries have solved this, right? If you go to Canada, you go to the UK, you get a single payer number, and it's all centralized. Politically in the US, that's difficult, if not impossible to do. But other countries, European countries, this is how they handle healthcare. The government manages it. There's a single system. It's kept up to date. Yeah, there's issues with it, but you trade one set of issues for another. Yeah. And the systemic issues, the technological ones, in the U.S. we should be able to solve. I mean, the U.S. is very good in technology, and there are a lot of companies who can do it.
But also, I think, like to Paul's point, I think part of it is actually by design. It's by design it is that complicated as it is, because there's no transparency. That also means you can get away with like charging for things and managing things. Yeah, you can get away with a lot more because it is so intransparent. If there would be full transparency, like in Germany, for example, there's 100% price transparency. No matter what provider you go to, whether you're a network, there is nothing like an in-network or out-of-network. You're going to pay exactly the same amount. You as a patient actually don't pay anything because it's like basically all included with your health insurance. But you are being charged, or the insurance is going to pay the exact same rate no matter where you go.
It's across, it's standardized, right? It's across. Yeah. For example, if somebody is going for knee replacement, it is going to be the same cost across all the hospitals, and that is the money which has to be paid.
Right. So that is good for you as the patient, but it's not. But on the flip side, that really inhibits innovation as well, because if you can only charge X amount, no matter how good your technology and no matter what you do is, then you may not invest in that next best system. Right. So again, it has all its pros and cons, but part of it is just, I think, intentionally built very intransparent really for the sake of
and the hospitals actually keep very close track of what they're spending. So when I was with him in the hospital room, there's this machine. I think the machine dispensed drugs into his arms. So the nurse would come up, she'd push a button, it would dispense something. And this thing, you could see it's sort of tracking what it dispensed, how much, and presumably there was some dollar figure attached to that went into the billing system. So they kept track of that very, very accurately. I got just one big number, right? I didn't get an explanation of like all the drugs they gave him and all the services he got and how they were billed. I just got the macro numbers from the different providers and what I owed. And then there's the EOB from the health insurance company, which is not much better. So did I need to see everything? No. Would I have liked a little bit more information? Yes. And to your point, both of your points, if you get something in advance, hip replacement, knee replacement, it's pre-authorized. So they'll send it over. They'll make sure the ICD-10 codes are correct. The CPT codes are proper. And then they will say, you are authorized for this. We will pay you that.
Yeah.
I knew that, I had my hip replaced, 8-9 years ago. I planned for it 6 months in advance. I adjusted my insurance policy so I'd have my deductible covered with money. And there were no surprises.
Yeah. It's insane, right? I also remember one of the stories that one of my friends' dad, he had to be hospitalized, and then he was in hospital for 3 days. And again, I think he had some kind of pain in his stomach, but there was no root cause analyzed and all. But the bill which was received, it was $150,000.
Yeah.
Yeah, it's insane. I mean, what if the person, for those who do not have insurance, where will they go?
Oh, yeah. And my friends are like that. You get the bill and then, the hospitals will write it off. I mean, when my son was born, he spent 3 days in the NICU. His blood sugar was low. There was some new procedure. They said, normally we feed you a bottle, but because of the new procedure, we have to send you to the NICU. So he's in the NICU by himself. I can't get him out of there for whatever reason. I call my sister, who's a neonatologist. She calls the hospital, is like, you can release him now. So we get him out. The bill is $50,000, $60,000, and they covered everything. But again, for a kid who was healthy, he didn't have any tubes in him. He was just sitting there in the ICU, and they'd stick him in his heel every 3 hours to check his glucose level. The kid's next to him. They're covered in tubes and things. They look like Borgs from Star Trek. I mean, it's pretty heartbreaking for a healthy kid. And now he's 6'4", by the way. But at the time, you're like, what? You couldn't get him out of here. He was like in NICU jail.
Yeah, and that's a situation for the family as well.
Yeah. Oh, yeah. The insurance company tells you what's happening. You negotiate with the doctor. They show you whatever parts you're going to get. And hopefully everything works out. And the bill lines up with, hey, we agreed to this. We have a contract or whatever. Yeah. It's those emergency situations or situations like you think are normal, like having a baby, that suddenly goes sideways. There's an infection. There's a complication. The kid doesn't come out.
Unknowns, basically.
Yeah. All the unknowns.
Will give you the surprises.
Yeah.
But I mean, like I admitted myself to the emergency room in a local, very well-known health system here in the Bay Area, and it was theoretically a life-threatening situation, but it wasn't like I was in danger like immediately. But I went to the doctor and they said, you need to go there and they need to check you. So I literally admitted myself there. I stayed a few hours and they checked me through and said, actually, you're okay. We'll give you some medication and you can go home. And then like weeks later, I got like this massive invoice of like whatever they said they did. And I was like saying like the cost that you have on here that is in no relation to what service you provided while I was there. And so I complained and they said, oh, like we can just give you 20% discount if you pay now. It's like, in what world do I live here? It's like I can negotiate with you of how much I'm paying for you to help me in like a health situation. That honestly, that made me even more mad, even though like I actually ended up paying 20% less. It was just like a ridiculous situation. So
when you say that, because after my hip replacement, I went to physical therapy and never got a bill. I thought, well, I wonder if the insurance is covering this directly. A year later, they send me the bill. I'm like, this is insane. Why'd you send me this giant bill? Why didn't you send me, the bill weekly? And they said, well, we sent it to this address. And I look at the address, I'm like, that's the address of your physical therapy office. That's not my address. Why would you send it to your own people? No, didn't get a straight answer. I said, I can't claim this on my FSA anymore. And you had a year. I can't even claim this on my insurance. So we haggled back and forth and they agreed to accept 50%. And I said, I insist on a letter from a VP or higher that this settles all claims. You will never sue me or give me back credit for this, that this settles anything and everything, and I have it reviewed by a lawyer. They agreed. They sent me the letter. I sent them their 50% off. But again, why didn't you, what went wrong that you're sending it to yourself and not recognizing that you sent yourself a bill for a patient?
This is a typical trap, I would say that. Yeah. And it's quite frustrating. And I think each one of us, they have some of the other stories to tell. We have Falko and companies like Lantern, those who are in between the provider and payers and really helping the claim system. So Falko, coming to your point, Lantern price claims are based on the submitted codes, right, directly coming out, and you do not look into the medical records as a TPA. So
it actually depends. So okay. we cover surgeries, cancer, and infusion. And for surgeries, yes, it is mostly looking at the codes. But we also still kind of check with kind of what journey someone went through. But on the infusion side, we actually receive claims, and then we receive PDFs with literally barcodes on them.
Yeah.
That is about what things.
So what if that barcode is not correct? That was the question coming to my mind, that where do you see the structured clinical signal which is going to really help you reinforce accurate code selection, right? Sometimes it might happen that the code is not correct, right? Which might go to denial or take the process more elongated. Instead of 5 days, 15 days, right? It's over extra work. So tell me, where do you see all of this coming? Do you think that there should be a structured process when you are doing the mapping coming from the provider sides, or what kind of automation can be done?
Since we guide our members through the journey, part of that guidance is also that we request our medical records. So we actually have medical records on our members on file. So our claims team may fall back on that for cases that are not easily for kind of non-trivial cases, I would say. But typically it is used if it seems unreasonable. Like if you look at kind of the claim and you look at the codes and you look at kind of what level of complexity was that. Based on that, does that make sense what they submitted? And if it doesn't, then I think then you may look back and kind of dig a little deeper and look at the actual history of what came down here. But yeah, when recently someone from our claims team showed me an example for an infusion claim, it was literally stickers. So like I said, barcodes, but in the hospital, when in the facility where you receive the infusions, and often it's part of a cancer treatment, but it could also be other reasons, they literally peel off these barcodes of whatever they give someone and they stick them on a piece of paper, which then is scanned and then sent to us. So, and sometimes there are 10, 15 stickers on a single page, and you're trying to figure out what the thing even is, because it's literally just a barcode and some, I don't know, Latin name of whatever that person was given.
So the process is pretty manual. So do you see some kind of automations can be done to make it much more accurate?
Yes. I mean, we similar to how we try to automate our claims pricing, we are also trying to use intelligence to use OCR to read these documents, not just kind of the codes, but really getting a lot more context. And for a human, that is a hard problem. But it's still deterministic. Once you've done it 100 times, now when you get it 101st time, you're doing a better job at it. And I think we are really trying to train our AI to kind of learning from what our team is doing there, so that we can replicate it more automatically.
Yeah. And Paul, would you like to add?
Yeah, well, he brings up a good point. This is, the providers, caregivers, providing proof of what we did.
Yes.
So they're saying this is the code and this is the stuff we did, so that if there's an error, you can catch it, because I think there's an acceptance that somewhere in the process there are going to be some mistakes, and not just a few of them. So what Falko was describing here, does it pass the smell test, right? I learned this years ago in engineering school. Does the number you calculated make sense? Think about it. Should it really be 100, or are you really looking for something in the single digits? It's the same thing here. Why does my ICD code not come close to this? Or why does it come close, but it's not quite right? And those little nuances can make the difference between a denied claim, a claim with further investigation, a fraud claim. I mean, a lot of things can go really sideways. So, they're trying to send all the proof to prevent that from happening, assuming that the receiver understands everything and puts it all together. And, you got a claims agent who's been there 15, 20 years, probably is not going to make many mistakes, is going to read the barcodes themselves. Got someone who's just out of training, that's going to take, twice, 3, 4 times as long, going to have errors. And to your point, process, AI, OCR, all this stuff comes in. I scan it. I look at this. Does it make sense? What have I learned? And you teach the AI the way you would teach the human.
Yeah.
And they learn and repeat this. And so a little aside, not to plug our company, but Teqfocus is a great little demo that we use at various conferences. And it shows an X-ray. And the X-ray and all the notes with it, and it can diagnose what the X-ray is. It's been shown tens of thousands of pictures of X-rays. Mm-hmm. And I have a cousin who's a nuclear radiologist. Like I said, I'm the only one who's not a doctor in my family. But so this one's a radiologist. This is what he does all day. But when you think about it, does the machine make mistakes? No. Why? Because it doesn't get tired. It doesn't get fooled by lighting in an X-ray. It doesn't forget to put on its glasses. It has learned what you've learned, but it makes no mistakes because it's always awake. It's always sharp. And if it senses anything wrong, it will tell you, I'm 99% sure. I'm 85% sure. You should review this. Whereas sometimes humans, I'm the doctor. And I have a lot of family members who are doctors, and God love them, but they're right about everything, anything, all the time. That's just sort of it's not a dig. That's just how they are. But the machine doesn't have an ego. And then maybe that's kind of a thing. It doesn't have feelings. It just does what it's been trained to do. And if you train it really, really well, it will check the ICD-10 codes. It will read that X-ray. Great example my wife was telling me about where an AI in a large hospital had gone through a case and it said, you should check for sepsis. And the attending physician told the resident, ignore it, does that all the time. It's a mistake. Patient died of sepsis. So now, I don't know what the history of it was, why he thought that, why he overrode it, but the AI caught something and he overrode it and he was wrong. So,
training is important.
Training is important. AI is a tool. This is what I tell everybody. It's not a replacement for the human brain, but it's going to tell you things. Mm-hmm. Do I listen to my father because he's older and wiser? Yes. Okay. Is he always right? No, but I certainly pay very close attention to what he tells me. Is the AI telling me something? Should I pay close attention? Yeah, but it's a tool. And it may have caught something you didn't catch.
Absolutely. So very well said that machines do not have egos. They do not get tired. So whatever they'll be trained on, if the data is good, so the results will be good. Yeah. Absolutely. So data being the critical part of it, how we are training the machines or AI models on top of it.
Well, it's the data. Wow. So a funny story for you. How many ways can you spell IBM? 16. Because I once had a vendor database that had IBM and they're spelled 16 different ways. Was it wrong? No. Was it duplication of data? Yeah. Could it have been cleaner? Yes. But that little kind of funny story tells you it's not just, the data is replicated. That's the other problem. It's not like the data is dirty, but I have the same data in a lot of places. Which one am I pulling from? Am I pulling from the right source, the wrong source? Am I looking at the right set of X-rays? Maybe an older set of X-rays? Is there a new research that should be incorporated? So it's not just the quality of the data, but it's, the source of the data, the replication of the data, the integrity of it. Has it been vetted? Has it been sterilized, so to speak? Has it been kept as a referential data set that you can always rely on that's sort of kept like a golden record?
That's what we have been clearly hearing a lot in the ecosystem, that data is king, right? Whoever is working on data, they have the power.
And hospitals here, they don't have a problem with data. They have too much data. And not all of it is relevant to what you're specifically doing, but matters in all this data I have about this patient and his family history.
Yeah.
What's important?
So, it is not easy since this ecosystem is that complex. So again, there is a variety of combination permutations on how the data should be perfect to make any model perfect. Okay. Thanks, Paul. Coming back to the claim management, I was thinking of the denials, right? Falko, you spoke about the overall journey, how it works, and a lot of steps you narrated. If you want to go ahead and tell us a bit about when denial actually happens in the claim management process, give us a couple of examples on when you see the denials are very frequent. What category it is very frequent?
One category is literally you're actually not our patient. That actually happens to us. It happens to us quite frequently. where we work with providers that are also in contract with other insurances, because we are so they may get it mixed up and they send it to the wrong one. So then we get it. But it could also be that this patient may have been a network with us, but now is not anymore. So to Paul's point, for a network, you switched like in our case, you switched your employer. Your previous employer had a Lantern benefit, the new one doesn't, but your provider doesn't know that, so they're submitting it to the wrong place.
So how do you think we can fix this scenario if this is like causing 10-12% of your denials, right? Are denials very frequent?
No, I think 10-12% I think seems pretty common of what I've heard so far. I think ours is slightly lower because we're also specialty network, so we cover like less, and we have very close connection with our providers, so the number of denials is generally lower. I think it may be like 5, 6, 7% maybe, but yeah.
But overall, industry-wise, you're saying that even I was reading it's close to some 15% or so. Do you think something can be worked on denial to make sure that the process is again seamless and denials can be reduced?
I mean, going back to actually having something like a true health insurance card that you use when you go to a provider, that may help, and rather than just like some paper copy or like some like laminated piece, it actually has a chip on it, just like your credit card, and it has your information on it, and you use that. It also solves kind of the identity problem where you may be John Doe in the one system, but you may be John Doe Jr. on the next system, and maybe you are Jonathan in the next system, and Jonathan may be misspelled in the next system. So it's actually all you, but you're misspelled in many different places. So I think that sometimes it's being denied because we think we don't know you, but it was literally just like a mistake in address or a mistake in the naming as well. So that could certainly contribute to reduction there. And I think having clear agreements with the providers of how they how we reimburse, I think also helps. Just that I think it's a little bit of a cat and mouse game. Like the provider generally tries to charge as much as they possibly can that they can get away with, and you on the payer side are trying to pay as little as possible that you can get away with, and you need to meet in the middle. So now that we are a specialty network, we have like a smaller list of providers that we're working with, and I think that's why we can be very efficient because we now work very closely with them. But in general, I think just getting to an agreement what is reasonable for like a procedure.
Yeah,
this has been solved in the auto insurance industry. If you go to get your car fixed, anything from a warranty claim to damage, they go to the Mitchell One database that says, okay, the water pump for a 2019 Ford F-150 truck is $110, and it takes 1 hour of labor. The only thing that's variable is the labor rate, which can vary from place to place in the country. And again, same thing in network, out of network. I take it to the dealership versus I take it to the local repair shop or someplace else. But if it's not contracted, then they can say, well, this is the typical rate. So there's no mystery. But there's a database, like a hip replacement should cost this. It should take this many hours. Doesn't matter where you are. It should take 2 hours. Should take this much anesthesia, this much in recovery, and maybe some variability based on age. But it's well known. It's a very common procedure, very, not nothing experimental. And the labor rate, again, is going to be very similar from hospital to hospital. So it shouldn't be a mystery. Why is one procedure $3,000 at one place and down the street is $2,000? Why am I negotiating for my health care? It's not like I'm buying, corn on the open market or head of cattle where I'm, at an auction. It's, and if this has been solved for healthcare, for automotive, for homeowners insurance, lots of other insurance, very long list of things, you would think it should be available for healthcare.
I mean, healthcare is the only place where you cannot ask how much this is going to cost. Like everything else in your life that you do, you go someplace and you want to get a service or a product and you ask them how much it's going to cost and they tell you, and then you're either happy with it or you're not. And sometimes you pay up front and sometimes you pay after, but you know exactly what you're going to pay. With healthcare, you can walk into a doctor's office and say, hey, I need this. Exactly this thing. Tell me how much it's going to cost. And they shrug and say, like, I can tell you 6 weeks later. I just really don't know. This is the only place that I came across where that's the case.
Yeah.
Given that pricing integrity and payment speed are core values, right, of Lantern. So what commercial models best align your incentives with employers and providers, transaction-based or PMPM, shared savings, or accuracy-based, or there is any other different?
So, I mean, in the past, I've seen PEPM. So it's rather PMPM. It's typically PEPM. So meaning you pay per employee per month. But that obviously assumes you still have your dependents covered as well. We are trying to provide different pricing models based on what our customers feel most comfortable with. I think it's still the vast majority is, I think, still on a PPM model. But we also have customers that are on like a shared savings model or like on a case rate model. Often, if you have customers that are or employers in our case that are maybe a little bit more skeptical about the value that like we or other TPAs or like other companies can provide, then they may go to case rate initially. But in the long term, it may actually be cheaper just spreading it out across your population rather than doing that. It also drives more engagement than just like purely looking at cost savings.
Great. That ad. So I think this one is going to be the last one. So for a payer side organization, TPAs like Lantern, health plan or employer fund, right? What does a realistic 12-month modernization path look like, Falko, or to you? So do you think?
Well, I mean, we have that mapped out. We actually just finished our planning for 2026. And for us, it is really focusing a lot on modernization and we're really trying to apply. I mean, in the past, you would have called it like operational efficiency and like workflow, automation. Now we're like also looking at really an AI-enabled workflow automation as well. Not all of it is going to require AI, but we're looking at modernizing the journey for our care advocates that are helping members, making that process more streamlined, using AI to like surface information before they need it so that they don't have to look for it, to make that easier. Like on the claim side, obviously we're trying to automate as much of that process as possible to like not only get to near real-time options for reimbursement, but also like increase quality and consistency. And I think that is achievable within a 12-month journey. If you make it a priority and you truly invest in it and get buy-in, not just from within like technology, but really across the organization, because it's really a big shift from how you may have operated in the past or currently.
Absolutely. And I'm super excited for your next 12 months journey. And coming to Paul, what is your vision? Where do you want to see the healthcare, especially since we are talking claim management today? So where you want to see this claim management thing in next 12 months across?
So, on the medical side, medical technology is amazing. I mean, they can save your life. They can do things that were just not possible even 5-10 years ago. So the medical technology is amazing. And the regular technology is impressive too. It needs to be applied to hospitals. It's always what's my ROI and somewhat short-term thinking, but really, a hospital wouldn't hesitate to spend $50 million on a new ICU unit or a NICU or a cardiac care unit. But you got to think about the technology in the same way. The technology is allowing the data to flow like a river as opposed to sitting in puddles everywhere in the organization. And it's a bigger investment because it's not like I'm building a NICU or a unit. I'm building the substructure, the infrastructure that encompasses my entire organization. Some of these solutions, they're out there. You can look at other pieces of the insurance industry, very established, highly automated, well standardized. If you have a car accident, everybody in the insurance industry knows you had a car accident, right? You can't go to Allstate and Nationwide if you had an accident, Liberty Mutual. They're going to know. So in that respect, there's transparency in big, large swaths of the insurance industry. Why that same principle can't be applied to healthcare? Yes, there's HIPAA and there's privacy, but all this other data is pretty private too. So I think some of the lessons that have been around in other parts of the insurance industry can be applied to the health payer piece of the insurance. When you think about it, you sort of separate it from the actual health care versus the payer side, which is strictly a financial transaction. That's no different from another financial transaction in the insurance industry. So I think a lot of those lessons need to be learned. There needs to be some investment. Certainly insurance companies like to know what's been happening to your health so that you're not doubling down on your insurance to prevent fraud, but at the same time, you're not being improperly diagnosed or treated by someone. So I think there's a lot out there that can be applied here. And, we all need to be sort of, I don't like to use evangelist as a word, but we sort of need to be pushing this idea that these solutions are there. They just need to be implemented.
All right. Then with that said, we come to an end to the podcast. Thank you so much, Falko. Thank you so much, Paul, for the wonderful conversation.